Welcome to Cardiovascular Medicine. This is Conrad Fisher, and I am an Associate Professor of Medicine, Physiology, and Pharmacology at Touro College of Medicine in New York City, and the Director of Educational Development for the Jamaica Hospital System in New York. And the most common source of questions on all board exams is always heart disease. Whether that be the American Board of Internal Medicine, Step 2 CK, Step 3, it is cardiovascular disease. As we go through, we will be addressing each of these diseases with the questions that we have discussed that we want you to be thinking of and have them in mind during the entirety of your studies. What is the most likely diagnosis? What is the best initial test and most accurate test? What is the best initial therapy? And in cardiovascular disease, we have two questions that are uniquely more common in this section. And that is, which of the following physical findings is most likely to be found in this patient? Now, that is because this section is the one that has Kussmaul's sign with constrictive pericarditis and pulsus paradoxus with tamponade, which has S3 gallops with congestive heart failure and S4 gallops with left ventricular hypertrophy, and we'll go through each of them. But it's very important that you understand that if you think that those physical findings are archaeologic, they are certainly not. They are alive and well and living on your Step 2 examination. And in addition, this section has more questions on the initial therapy is given and it fails. What would you do next? So subsequent therapy. So it's not enough to excel on your Step 2 exam just knowing that aspirin or thrombolytics or aspirin angioplasty is sufficient for a myocardial infarction. You've got to know, well, what happens when it fails? Well, the thrombolytics fail. What would I do next? Angioplasty. Well, the aspirin and the clopidogrel fail. What would I do next? Switch to prasugrel or ticagrelor. Well, the therapy fails and they develop a complication of MI. What would you do next? And that is unique for this system. I am 100% confident that by the end of this section, you will have been able to extract all the questions, and I mean all, so that there will be no surprises on your test day. In this section of coronary artery disease, we're going to be looking at the definition. What is the very definition of what does it mean to have coronary artery disease? What are the risk factors for that disease? And what is the clinical presentation that will allow you to answer the critically important question on Step 2, what is the most likely diagnosis? Let's be clear that the terms coronary artery disease, which is our preferred term, can be used interchangeably with atherosclerotic heart disease or ischemic heart disease. Essentially, they all mean that there's insufficient perfusion of coronary arteries, starving off the myocardial muscles from abnormal narrowing of the vessels. Now, in this case, it doesn't necessarily imply how much narrowing. It could be 40%, 70%, 90%, and it's not saying right now whether it is a critical 70% where we do surgery, but simply what are we referring to when we use the term coronary artery disease. Also, because you will hopefully be using multiple sources of books as you're studying or when you're looking at various Q banks and you see these terms, you don't want to be fooled into thinking that they're talking about anything different than simple narrowing of the coronary vessels, which basically starve off the myocardial system of oxygen, leading to chest pain and ischemic heart disease. My strong suggestion is that you pause the audio recording so that you can read the question, and I will summarize the question to you in order for it to be efficient in your learning. This is a 48-year-old woman. As 48, she's neither very young nor very old. The second thing is that this is atypical chest pain. The pain is not reliably related to exertion. There is no pain now. The location is correct, which is retrosternal, and sometimes associated with nausea is incredibly nonspecific. And she has no past medical history. So the most likely diagnosis in this case, in a woman with no risk factors. The most likely diagnosis in this case, in a young, healthy female with no risk factors, is reflux disease. Now, risk factors matter for people who are not very old. For instance, if the case describes to you a 75-year-old man who's having chest pain while walking up a flight of stairs, risk factors are not relevant because, in fact, 1 out of every 5 people who presents with a myocardial infarction, their chief complaint is, I'm dead, sudden death. You don't have to have any risk factors in an older person. However, for somebody like this, it is extraordinarily rare to have coronary artery disease in a menstruating female. In the entire 60 years of the Framingham studies, there was not a single myocardial infarction in a woman who was menstruating. However, in this case, because the location is retrosternal and there's GI complaints, by far the most likely thing is reflux disease. Unstable angina, it cannot be simply because it is not the most likely. Now you have an advantage on step 2 questions because the diagnosis questions don't say the diagnosis is. Could you say categorically that 100% there is no coronary disease? No, you could not say that. But the questions on step 2 don't say the diagnosis is. The questions simply say most likely. And 99.9% chance this is not coronary disease. So we have unstable angina if there's an emergency department, and remember we will be using the term emergency department, not room, and pericarditis gives you pain that is positional and pleuritic. It's better when you sit up and worse when you lie down. Positional and pleuritic and sharp pain. A pneumothorax is associated with shortness of breath. It also has sharp pleuritic pain, and if it's a tension pneumothorax, it will shift the mediastinum to one side. Now, the only one that is close to being a possibility is Prinzmetal's angina, sometimes called variant angina, which is vasospasm. It is an extraordinarily uncommon disease, resulting in roughly 1/10 of 1% of chest pain. In the most generous of circumstances, Prinzmetal's is an extremely uncommon disorder, and it would also be impossible to look at it without seeing that there was ST segment elevation. So it is highly unlikely with this presentation. So could it be Prinzmetal's? Yes, but reflux disease is roughly 1,000 times more common, and there are also no GI complaints with Prinzmetal's angina. This patient, who is under the age of 50 and menstruating, is exactly the patient for whom risk factors are indispensable to know. In a person like this, who had no risk factors, the likelihood of ischemic heart disease is virtually zero. Menstruating women virtually never have an MI, and the risk factors are important when you're not clear. Risk factors are not important in the old man walking up a flight of stairs. Now, if you said that this person was 48 years old, but as a person I met yesterday, who had been on dialysis for the last 23 years and had been diabetic since she was 13, yes, as a person who had been diabetic from the age of 13 to 40 and in dialysis of 15 to 18 years, yes, by 40 that woman could have had coronary disease. But you would have to have an extraordinarily overwhelming history of risk factors to have coronary disease in an under 50 woman. Which of the following is most likely to benefit a patient's risk of coronary disease? And the answer is, well, exercise is far more important. Now, there are a lot of things here that we thought at one point would make a difference. For instance, estrogen replacement. This was an idea in the 1990s that looked at the fact that, as we just said, menstruating women don't have myocardial infarctions. However, that did not translate out into give the women estrogen and everything will be fine. Not at all. Matter of fact, not only did estrogen replacement not decrease the risk of coronary disease, there was actually a slight increase in the mortality by estrogen replacement. So therefore, although it may be that menstruating women don't have MIs, you cannot simulate the effect of estrogen that you get from a normal menstruation by giving it as a pill. That does not work. Stopping tamoxifen is irrelevant. Although tamoxifen is a very interesting selective estrogen receptor modifier, tamoxifen is antagonistic on breast but agonistic on bone and your endometrium. Nevertheless, though, it does not translate out into any effect on the coronaries. Aromatase inhibitors result in a complete blockage of estrogen throughout the entire body because aromatase is responsible for creating estrogen in the ovaries and the Sertoli cells of men and in adipose tissue. But there's no relationship of aromatase inhibitors to coronary disease. And relaxation methods, well, we all should relax. The problem is it's almost impossible to define. It's a very nice idea, but what exactly does relaxation mean? No one can define it. And it can't be measured, so therefore, since you can't measure it and you can't define it, it's been impossible to study to know reproducibly whether relaxation methods really lower a risk of coronary disease. The clearest risk factors for coronary artery disease are unquestionably diabetes, which is the worst risk factor, tobacco smoking, which is common, but not as common as hypertension. Hyperlipidemia, But hyperlipidemia as a single risk factor is not so bad if you haven't had coronary disease. The hardest one to understand is premature risk factors of coronary disease in your relatives. That the age cutoff for a male relative is if they had premature disease, defined as a father who had their disease under the age of 55 or your mother under the age of 65. So the family history is 55 and 65 for male, female. Whereas your individual risk is at the age of 45 at a man and 55 as a woman. Now, we're going to say this again because those numbers are very difficult, but it would make a huge difference because let's say a person has a borderline level of LDL, like an LDL of 160. An LDL of 160 in a person with zero risk factors does not get statins. But an LDL of 160 with 2 risk factors would get statins. So that's why it is that if you are a man at the age of 46 and your father had coronary disease at 54, as annoying as those numbers may be, it means you get to eat statins for the rest of your life. If 1 year is different, you don't have the statins. Please memorize it. Thanks. The worst risk factor would mean which of these gives the highest likelihood of developing coronary disease at the end of a certain time period? Well, the worst risk factor is unquestionably diabetes. If you take a group of people who just have diabetes, just have hyperlipidemia, just smoke tobacco, just have a family history, then unquestionably at the end of 5 years, the group that has diabetes has a single greatest risk of developing coronary disease. Now, hypertension is the most common risk and is defined as having a high blood pressure above 140/90 in the general population. That's 130/80 in a diabetic, but it is much more common to have just hypertension alone than to have hypertension with diabetes. There are about 16 to 17 million diabetics in the United States, about 10,000 new diabetics a week, but there are 60 million hypertensives in the United States, 20% of the total population. And half the people who have high blood pressure are unaware that they have it, and even the half that do have it are not sufficiently controlled. So overall, only 1/4 of people who have hypertension both know they have it and in fact are completely controlled in their blood pressure. Family history is not a risk factor if that family history developed in elderly relatives. If your mother, father, aunts, and uncles, and your dog all have coronary disease at the age of 80, it doesn't count as a risk for you or for the patient in the question on your test. It does not matter if it's in grandparents, cousins, aunts, and uncles. It's only a risk factor if it's first-degree relatives, siblings, and parents, and if that disease is premature, defined specifically as a male relative under 55 or a female relative under 65. Which of the following is the most dangerous to a patient in terms of the risk for coronary disease? Well, this question, which I hope will be one of the easier ones, is a high LDL. Triglycerides are not as important a risk factor as LDL. Now, we simply do not know what to do about triglycerides. We know that when they're elevated, there's a modest risk. We know that when you lower them, you have a modest improvement. However, it's not categorically clear what to do about them. And even when the triglycerides are up, the best initial therapy is still a statin, not fibric acid derivatives. Fibric acid derivatives may lower triglycerides more than the other therapies. However, that's not the same thing as saying it lowers mortality. Statins lower mortality, so even when there's high triglycerides, one, as an isolated figure, it's not clear that you actually have to even treat it. We think we do when it goes above 400, but we're not clear what to do about it. The total cholesterol has to be fractionated out. And a low HDL is a risk factor, and a high HDL takes away a risk factor. Get out there and run. Matter of fact, put this on a recording and run with it and listen to me and raise your HDL and raise your step 2 score simultaneously. And it takes away one risk factor. Obesity is a very interesting risk factor in the sense that the danger of obesity is almost entirely from the fact that it makes you diabetic, hypertensive, and hyperlipidemic. Obesity by itself, interestingly enough, is not that bad. If you have high body fat, but you don't have diabetes, hypertension, and hyperlipidemia, one, it's not that big a risk. Second, if you exercise, it almost entirely reduces your risks to normal. So if you're big, just don't be too sweet, diabetic, or too greasy, hyperlipidemic. Less clear risk factors are physical inactivity, excess alcohol, fruits and vegetables not being enough in the diet, certainly emotional stress. But the difficulty is it's very hard to define a lot of these. For instance, how do you define emotional stress? Very hard to put a number on it. Can't measure it, can't define it hardly. And the issue about excess alcohol is hard to define. What do we mean by excess? Certainly 4 and 5 drinks a day is excess. Is 2 or 3 a day excess? Hard to define. Now, calcium CT scoring. This is very problematic because some of you are going to be rotating through places where your attending, who supervises you and writes your evaluation, believes that CT calcium scores is extremely important. Now, this is one of these areas where you may have to say one thing to get a good grade on your third-year student clinical rotation or on your sub-internship, but not answer that on step 2 of CK. So you, on your rotation, should do what your attending tells you and discuss it with him. And you do not have to believe that CT scoring is unclear. You just have to answer it on step 2. Calcium CT scoring simply is not clear how that adds to thallium stress testing, regular stress testing, or angiography. So calcium CT scoring is associated with an increased risk of coronary disease, but it's not clear what to do about it, and it's certainly not a standard care test at this time. PET scanning is a test to be able to look at the content of lesions or masses to see if there's cancer in them, but PET scanning will not help at all in coronary disease. Of all of these, the hardest one to get right is the CT scoring because maybe someday it will be a real risk factor, but for right now, the answer on calcium CT score is no. We have a postmenopausal woman who develops chest pain suddenly upon hearing the news of her son's death. She develops this chest pain and shortness of breath and ST segment elevation in V2 to V4, which are the anterior leads, and the troponins rise. So this is unquestionably a real myocardial infarction. However, the coronaries are normal, and there's no spasm. There is a test you can do called ergonovine stimulation, which looks for spasm. At the same time, the echo shows apical left ventricular ballooning, outpocketing. What is the mechanism of this disorder? Well, we think that this is a massive catecholamine discharge. This is also known as Takotsubo cardiomyopathy. It was described in Asian women who developed a sudden apical ballooning and a myocardial infarction in the absence of coronary disease. Now, this is not for a person, interestingly enough, who yells and screams and is upset all the time. It's actually for someone who's calm and quiet and suddenly becomes extremely upset. That's in whom it can be damaging. Remember, Takotsubo is in a person who's not used to being upset and highly emotional. So therefore, if you're going to stay calm all the time. Now, absence of estrogen will not cause sudden death such as this. And although plaque rupture can occur, there's no plaques. The coronaries are clean. And platelet activation happens from a rupture of plaques in MI, but not in this. Again, platelet activation is when there's coronary disease. Emboli also is a very atypical cause, but can happen that you have emboli to the coronaries. But it would have been seen. Takotsubo cardiomyopathy. At this point, also, it's very important you understand that this is an excellence tool. So if you haven't heard of this before, it means that we're bringing you up to get that 270 score. There's no specific therapy for the Takotsubo beyond what you do for coronary disease. And there's no ability to fix it through angioplasty. There's no ability to fix it through thrombolytics because there isn't a plaque. It isn't a clot. Now, unreliable or unproven risk factors of coronary disease, which mean if you see them in the question, you're to ignore them, are homocysteine. This test has been around for 50 years. We still don't know what to do with it. It can be used as a diagnostic test in folic acid deficiency or B12 deficiency occasionally, and it's asked about for B12 and folic acid deficiency, of which it goes up in both. However, for a risk factor for coronary disease, it simply is unclear. Chlamydia infection was a 1990s idea that is in old questions and is essentially passé. C-reactive protein, well, we do know that's an inflammatory marker, but the key issue in all these risk factors is we simply don't know what to do about them. There is no clear benefit in therapy on any of them. So if they're up, they're elevated, they're abnormal, what do you do about it? Nobody knows, so that's why they're not clear. See, LDL is clear. Coronary disease and LDL above 100, clear. Statins. Hypertension above 140/90, clear. Lower it. Those are clear things. You can't do anything about these others. They are the wrong answers. And when you go into step 2, knowing the wrong answers can be as useful for you as knowing the right ones, because then you know what not to choose. The most common wrong answer in the risk factor questions is always the one on the family history, where people are mistaking the coronary disease in the elderly relatives. And it means that they show you a person who's old and say, is there risk factors, or what do you do about the LDL? And you make the mistake. Just remember, risk factors in a family has to be young. Correcting which of the following risk factors is going to result in the most immediate benefit. That's the key word here, immediate benefit. Stopping smoking results in the greatest immediate benefit. If you stop smoking, your risk starts to go down literally 10 minutes after you stop smoking. A week and a month and 6 months later, your risk of all kinds of diseases goes down within weeks and months. And if you haven't smoked for 7 years, your risk of lung cancer goes down almost to a non-smoker if it's been more than 7 years. But not so with diabetes, not so with hypertension or hyperlipidemia or weight loss. These other things, you must fix them, but stopping smoking results in the greatest immediate improvement in overall outcome. How do I answer the what is the most likely diagnosis question? Ischemic pain will have to be described as dull or sore. It's going to feel like being punched. Sort of like if you go to the gym and you exert yourself too much, you lift too much weights, you run too much. It's sore because the heart's a muscle like any other. And it's described as squeezing or band or pressure-like. Like any other muscle that's starved for oxygen, it gets sore when it's ischemic. Now, ischemic muscles are not sharp like a knife or point-like. If it's described as a person putting a single finger on it, it's extremely unlikely that a single finger or point-like pain is ischemic in nature. And ischemic pain does not just last for a few seconds. Ischemic pain lasts for a few minutes or half an hour, 30 minutes, 20-30 minutes. Non-ischemic pain lasts for a few seconds, and ischemic pain lasts for 10 or 20 minutes. The advantage of a board question is that if they want you to know the answer, they have to tell you something. Now, in life, 95% accuracy or sensitivity for chest pain would not be enough. That would mean out of every 20 patients who came to the emergency department, 95% sensitivity would mean one of those 20 would be improperly discharged. However, on step 2, if they tell you that the pain changes with respiration, it is pleuritic, especially that it gets worse when you take a deep breath, when you stretch that pleura, that is enough as a single factor to tell you, most likely diagnosis, not ischemic. If it changes with position, most likely diagnosis, not ischemic. Things that change with position are mostly pericardial. Things that change with respiration are pneumonia is pleuritic, pneumothorax, pleuritis, pulmonary embolus, pericarditis are all pleuritic. And if there's tenderness, it tells you it's not ischemic in nature. Each of these, positional pleuritic or tender, positional pleuritic or tender, tells you that there is no ischemia with 95% negative predictive value. Did you know that for every 100 people who come to the emergency department with chest pain, only 10% actually end up being diagnosed with a myocardial infarction? It's actually closer to 8%. As a matter of fact, The entire frequency of ST segment elevation MI is going down. That's because preventive medicines are so much better. When you have people from the very first moment that they're defined as having coronary disease, that they're on an ACE inhibitor or beta blocker or statin and an aspirin or clopidogrel, when you have so many of these drugs that work in lowering mortality, for every 100 people who come to the emergency department, 50% of the people with chest pain don't have anything cardiac at all. They have reflux disease, they have ulcers, there's nothing cardiac at all. And of the 50% that have something cardiac, the majority of them simply don't have coronary ischemia, and certainly not an acute coronary event. MCC, most common cause, MCC, of chest pain that isn't ischemic is in general GI things as one group. That would be things like reflux, ulcers, and gallbladder disease. We need to be able to answer the question, what's the most likely diagnosis? In order to be able to do so, we have to be able to understand the key words in the case that will allow us to do that question. Now, if the question says that there's a duration of pain that's only a few seconds, that is not ischemic pain. And if the question says that the duration is 5 and 10 hours, that is not ischemic pain. Ischemic pain is not seconds and it's not hours. More stable angina will last a couple of minutes, but pain that is more consistent with unstable angina or myocardial infarction lasts on average 10 to 30 minutes. Now the pain, the quality is incredibly important. Typical pain is squeezing, tightness, heaviness, pressure, burning or aching, like any other sore muscle, like going to the gym and exercising too much. It's sore, it hurts, it feels like being punched. Non-ischemic pain is sharp, sharp like a knife, point-like, stabbing, knife-like. When a patient says he can point to his pain with one finger, that is not ischemic in nature. Now, even more important is the location. Ischemic pain is substernal in location. Non-ischemic pain is left-sided. Left-sided pain is not ischemic 90% of the time just by saying left-sided. When the patient says left-sided, it's not ischemic. Ischemic pain and typical pain is typically provoked by physical activity, exertion, the cold, emotional stress, shoveling snow in winter. Ooh, that's it. Boy, that's fatal. And also the alleviating factors such as rest. Ischemic pain occurs with exertion relieved by rest. That's the story. Radiation is one of the least important things because it's not there most of the time. However, when it is there, when it radiates to the neck, the jaw, the teeth, the arms, and shoulders, that's very characteristic. And associated symptoms is very nonspecific. This is not as important to answer the question because so many things such as a pulmonary embolus, pneumonia, pneumothorax can give you shortness of breath, nausea and sweating, diaphoresis, well, pneumothorax, pulmonary embolus, pericarditis, pleuritis, all of those can give you sweating and dizziness, lightheadedness, or fatigue. So those are not as important. That's why I bring them up last. Remember, down to the bottom line is ischemic pain is not tender, not change with position, and not change with respiration. It's not positional, pleuritic, or tender. It's not positional, pleuritic, or tender. In cardiology, not only physical findings, but the question, what's the most likely diagnosis and most accurate test, are critically important. So if the case describes chest wall tenderness, your answer for the most likely diagnosis is costochondritis, also known as Tietze syndrome, or simply musculoskeletal pain. The most accurate test is, well, there is no real physical test except the physical examination. When it radiates to the back and there's unequal blood pressure, I saw this just today, an aortic dissection is critically important. An aortic dissection with pain radiating to the back. A chest x-ray will show a widened mediastinum, as we saw today. Just remember the CT angiogram, MRI, which is magnetic resonance angiogram, and TEE are virtually interchangeable. They're all over 90% sensitive and specific. Pain that gets worse with lying flat and better when you sit up is from the stretch of the pericardium. When you lean back, you stretch the pericardium, it hurts. When you lean forward, you unstretch the pericardium and it feels better. You should see on the EKG ST segment elevation everywhere and PR segment depression. If the case describes that there's epigastric discomfort and the pain's relating to eating, well, of course. And when I say relating to eating, I don't necessarily mean it's worse by eating, because whether it's better or worse is not as important as simply whether it changes with eating, and that is ulcer disease, and you need to scope that person. Now, bad taste is because reflux disease hits the ninth and 10th cranial nerves, supply bitter taste to the back of the tongue, and that's to help you gag things out. You don't want things tasting nice and sweet back there. You're more likely to aspirate. So bad taste, the acid hits it, and acid doesn't taste good to begin with. And the other thing is that bitter taste in general is in the back of the tongue. And you need to be able to just give a response to PPIs, liquid antacids, to make that diagnosis. Now, people with chest pain, it can be very difficult. It can be very difficult to distinguish these. That's why this is a great most likely diagnosis question, to be able to say, well, there's sputum and hemoptysis. You also will notice that chest x-ray and the presence of fever are very important, because did you know that myocardial infarction causes fever as well? Fever can't be used to distinguish an MI from the others. That a pulmonary embolus causes fever, and pneumonia, of course, but all clots, such as a pulmonary embolus or myocardial infarctions, all clots and all collections of blood can cause a fever, not just infections. Now, if the case describes the sudden onset of shortness of breath, tachycardia, and hypoxia, a pulmonary embolus, and remember that the pulmonary embolus is much more likely to be pleuritic in nature, the spiral CT is the standard of care. VQ scan has now become much less frequently done. It would be done if there was an equivocal spiral CT. If there's sharp pleuritic pain, well, sharp pleuritic pain can be with pneumonia, pneumothorax, pericarditis, pleuritis, but tracheal deviation is a pneumothorax, and you see it on a chest x-ray. The features that don't help you answer the most likely diagnosis question. Nausea is extremely nonspecific. Fever is nonspecific. Even atelectasis causes a fever. That's why a pneumothorax can cause a fever, because atelectasis causes fevers as well. Pericarditis causes a fever because any inflammation can cause a fever. Shortness of breath is far too nonspecific, because simply having chest pain itself, pleuritic pain, can simulate shortness of breath because people are splinting. Splinting. It hurts when I take a deep breath in. It simulates shortness of breath when people are splinting. And sweating is with all of them. So these features are common to virtually every form of chest pain and will not help you answer which of the following is the most likely diagnosis. Ignore them.